Good morning, everybody. Bright-eyed and bushy-tailed. Thank you for being here for the second day and coming back. I hope you enjoyed yesterday. We really did too. We laid a powerful foundation by exploring alcohol-associated liver disease and autoimmune and rare liver diseases yesterday. And today, we turn our focus to metabolic liver diseases in the morning sessions, and then in the afternoon sessions, we will be talking about viral hepatitis elimination at the intersection of harm reduction. We have amazing speakers here today. And so as we move through the program, we are going to keep on time today. I have a strategy. I don't have a bell. I do at home. I wish I would have remembered, but will be the sound to give a 5-minute warning to everybody. So I promise we'll keep us on track because we have to be on that boat tonight. Registration's at 5:30, like just getting ready to board, and then we sail it promptly at 6. There'll be dinner and music and a fun game show with the Yajagoff podcast will be with us again. And we hope you enjoyed the Choperation event last night. We're trying to keep you entertained as well as educated. So continue to share and learn and network. A couple of housekeeping before I introduce our keynote speaker. We have the iPad again, so make sure that you have your passport for today and that you visit the exhibitors and have them stamp your passport, and there'll be a drawing at the end of the day, and you must be present to win. So we want to make sure that you know that. And the evaluations every day are happening online, so during the program, you can find that and tell us what you thought. We want to hear what you liked, what you want to see more of, what we can do better or different. So, and if you want to be a part of it and planning for next year. So we appreciate that. But it is now my pleasure to introduce our keynote speaker, a good pal of the Community Liver Alliance, Dr. Jay Behari. And Dr. Behari is a nationally recognized hepatologist and researcher whose work has advanced our understanding of metabolic dysfunction-associated steatohepatitis, or MASH. He serves as a leader in both patient care and clinical research, bridging the gap between cutting-edge science and real-world practice. His expertise spans the full spectrum of liver disease, but his focus on metabolic liver conditions has been instrumental in shaping how we diagnose, treat, and prevent progression for millions of patients. He has contributed extensively to research on the pathophysiological of MASH and clinical trial development and strategies for early detection and intervention. And Dr. Behari's work reflects the very spirit of this gathering where science, clinical innovation, and patient experience converge to drive progress. We are honored to learn from Dr. Behari, and so please join me in welcoming our esteemed speaker, keynote speaker today, Dr. Jay Behari.
Good morning. Thank you, Susanna, for the kind words. Always a pleasure to be part of the CLA events and the amazing other organizations that I've gotten to meet today. So this is a really incredible forum. Susanna has put the fear of God in me. 20, 30 minutes, Susanna. I'm going to stay on time. These are my disclosures. So today I'll just talk about some updates in the diagnosis and treatment of MASLD and MASH. We'll talk about what's just beyond the horizon. I won't talk about very early stage clinical trials and developments that would take more than 30 minutes. And then some unsolved challenges and unmet needs, and I'll try to set the stage for the esteemed speakers that will follow me on the panel discussion. So let's jump in and talk about some updates. And this is a recent paper from Dr. Yanosi, who's a very distinguished hepatologist in Washington, D.C., which gives you a graphical outline of MASLD. And unlike what most people realize, we've known about this condition for over 100 years, almost 150 years since it was first described. But the history of modern MASH really starts with a very groundbreaking paper that was published in 1980 from the Mayo Clinic, where they started to notice fat and inflammation and scarring fibrosis in biopsies of patients who swore that they had never consumed alcohol in their whole lives. And that paper that was published in a very obscure journal was really the start of the modern era of MASH. And then no one really paid much attention to it because we were so overwhelmed with hepatitis C, which was discovered in 1990. The whole field focused on hep C for the next 30 years until in 2015 when we got the direct-acting antivirals. And then suddenly within 2 years, we treated everybody with hep C. Now I see one hep C patient in 6 months, which used to be the highest clinical skill set when I was in training 20 years ago. So it's really remarkable how much progress we've made since that time. And of course, in the last 10 years between 2015 and 2025 is where all of the development is taking place, which has led to, in the last 3 years, some very, very exciting changes that I'll talk about next. It's also important that we understand that as we switch focus from hep C, at least in the US, where hep B is less common, it's certainly not a problem solved in Asia and in Africa, but certainly in the United States, where hep B tends to be less common, MASLD and alcohol have become the two most important conditions. And I put this slide here to make the point, everyone talks about obesity, everyone talks about type 2 diabetes, but the prevalence of MASLD is higher by a lot compared to individuals that are living with type 2 diabetes. So really, gatherings like this, organizations like the CLA, I think play a very, very important role in raising that awareness. This is a slide that I'm sure all of you are familiar with in some way or the other, but if you're not steeped in the MASLD world like I am, this is an important slide because it really lays the foundation for a new terminology, a new nomenclature that was after a 2-year-long, very thoughtful process. And now we call this condition steatotic liver disease. Yesterday, my colleague, Dr. Alison Faust, talked about alcohol-associated liver disease. And so MASLD is one end of that spectrum of steatotic liver disease or fatty liver disease, as we used to call it. And then there's the new terminology of MET-ALD, which is increased alcohol intake in individuals who have concurrent metabolic dysfunction. And then on the other end of the spectrum now are conditions such as Wilson's disease and others where we can identify a specific reason for having increased fat in the liver. And then there's also some true cases of cryptogenic SLD where we don't really know why someone has. And I have maybe a handful of patients like that, and they probably have some undetermined genetic polymorphism or mutation that is causing a problem with their fat metabolism. There's a new definition that includes cardiometabolic risk factors in our definition, so you need to have increased fat in the liver, no alcohol or almost no alcohol, plus one of the cardiometabolic risk factors that are the standard definition of metabolic syndrome: blood pressure, diabetes, and dyslipidemia or abnormal lipid profiles. So this is a very important conceptual advancement, I think, since we used to call it non-alcoholic fatty liver disease until 2 years ago. So the question that came in our field was, what's the overlap between our old definition and the new definition? And it's very reassuring that in the two large studies that have looked at it, one in Asia and one in Europe, there was almost perfect concordance. So that means we can still use our data from 5, 10, 15 years ago and derive some meaningful insights from it because the definitions are almost completely overlapping. The other important study that came out a few years ago is this idea that fibrosis or scarring of the liver is what really determines bad outcomes or bad events in our patients with MASLD. The other important thing to realize is it's got a very long time course, and it's almost always asymptomatic. Most of our patients don't know that they have this condition until they present with a life-threatening complication, whether it's cancer or a GI bleed in the middle of the night. And so it's good news and bad news. The bad news is it's so minimally associated with symptoms, so it's very easy to ignore it, especially if the awareness is low, even amongst patients, or now increasingly I'm finding amongst primary care physicians and endocrinologists. So we have a lot of work left to do there. But the good news is it gives you plenty of time to reverse the course of disease, whether through lifestyle, diet, and now increasingly some very exciting medical therapy. And this is a point that I just made, is that increasingly the burden of diagnosing and risk stratifying is falling on primary care physicians. We have a lot of work to do in our communities to teach our primary care physicians. So for those of you who are medical professionals, or if you are a patient, please feel free to tell your PCPs to be aware of this condition. And if you do have cirrhosis, or you have a family member that is known to have MASH-associated cirrhosis, the risk in first-degree relatives is 10 times higher. So absolutely, first-degree relatives who have cardiometabolic risk factors should get screened, and that's really important. And the graph on the right is from my clinic, where we are finding that a majority of patients that are coming to me in a transplant hepatology clinic are very low risk. So clearly, our resources could be better utilized with more primary care risk stratification. There have been some recommendations in the last few years on who should be screened. And an important group that was first proposed in the Endocrine Society was in individuals that have either severe obesity, or they have type 2 diabetes, or they have persistently high liver enzymes. And there was a global consensus, actually it's coming out next month in October's Gastroenterology, which has now formalized that definition. They're really recommending, if you have type 2 diabetes, they do not include pre-diabetes in this recommendation, or if you have obesity with one risk factor in the metabolic syndrome, or if you have persistently elevated liver enzymes, you should be screened. And they're asking for a single risk stratification, and we'll talk about that. It's called Fibrosis 4 Index. And then those individuals who are at risk should get further risk stratification. So I think it's a great start, but I'm not sure we have solved the whole problem. The other very exciting news has been the approval in the last year of the first ever therapy for MASH, and it's been specifically approved for stage 2 or 3 scarring, which is, we estimate, perhaps 5 to 8% of the general population will be at that stage. But this is very exciting, because within 1 year, this study showed that in 25% of patients, there was a reversal of scarring. Because remember, that's what matters. It's the scarring that will predict who's going to have a bad outcome. And so it's very exciting that it showed improvement of scarring in this study in about a quarter of patients. So still some work to be done, but it's an exciting start. Now, it's important that this is a conditional approval, and there are some concerns that they might be rare cases of patients that may have elevation in liver enzymes, whether or not it's true liver toxicity. So we do have to monitor these patients very carefully. In my clinic, the protocol is to get blood work at month 1, 3, and 6. And if you're okay at that time, you're probably going to be okay, which is a majority of patients. And then we also have to know that at 1 year, patients may progress. We've had true treatment failures now since last year, and so we have to stop the treatment at that point because of futility. And so these are very quickly and rapidly evolving concepts that will probably change by next year. There's also a new guideline which is now suggesting we don't rely on liver biopsy. So a big challenge for us has been, how do you define the conditions that should be treated without doing a liver biopsy that most patients are very reluctant to consider? And so these new guidelines are suggesting that we use FibroScan or transient elastography with some specific cutoffs that they have recommended. We don't have to talk about the details, but generally remember 8 kilopascals is a number that's really important, and anyone that's above that should be considered for treatment with appropriate follow-up. And there are some situations where if the number is more than 16, then we really have to stop and think whether the patient may already have cirrhosis, in which case these drugs are not yet approved. The other very exciting news from 3 weeks ago is or 4 weeks ago, I guess, is the approval for Wegovy or semaglutide for the treatment of MASH with F2, F3 fibrosis. Since so many patients are on this drug for type 2 diabetes, this is very exciting news for us, because that will be a very significant overlap with our patients. And the response rate for scarring with semaglutide was 35%. So we're slowly inching up. Of course, the problem with this study, as I'll tell you, not the study, but the drug, is that many of our patients are unable to tolerate it. So again, a lot of work remains to be done. And this slide shows you that in a third of patients in this clinical trial, which is a pivotal study published a couple of months ago, there was a third of patients who had very significant nausea, diarrhea, and constipation. In my practice, I'm finding it's more than 15% of patients will not be able to tolerate the drug. 15% was the number in some of the pivotal trials of semaglutide for obesity. The number was very small in the MASH study, so we're not sure if different populations will respond differently. But in general, this is a pretty significant limiting factor, which may or may not be present for other drugs in this class. So quickly then jumping on to what's on the horizon for the management of this condition. I think a very important diagnostic problem for us as clinicians, for patients, for primary care physicians, is how do you decide who has to be treated and how advanced your liver disease is? And I can tell you that in our region, I think there are just about 8 or 9 FibroScans in a very, very large geographical area of Western Pennsylvania. And our patients have to come from Altoona or Hammett or Williamsport just to get risk stratified. So I think we've got to come up with some better blood-based biomarkers. I'm not going to talk about all of the research that's going on. I think there's a talk later today about, or maybe a breakout session on emerging biomarkers. But I think blood-based testing should be what we are working towards. So the Enhanced Liver Fibrosis Panel, or the ELF panel, is something that is now FDA approved. We are using it in our clinical practice. I have very limited experience with it outside of clinical trials that we're doing, because most of our local insurances are not covering it, and patients are being stuck with a $1,500 bill, which is ridiculous. So I've become very skittish about ordering it so far. Hopefully that'll change in the next cycle. We review our fibrosis policies once a year, so hopefully we'll have a chance as more data comes in. And there's a couple of different cutoffs there. The manufacturer says 9.8. I kind of use 9 to 9.2 as my cutoff for F2 or stage 2 fibrosis for deciding who to treat. But it's a nice emerging technology that's FDA approved, and I think we should hopefully be more comfortable and familiar in the next few years. There's other more exciting biomarkers coming. There's also a very exciting treatment landscape. Here's a slide showing you all of the phase 1, 2, and 3 studies that have been done in the last several years. And the green circle, so all the circles are clinical trials that my research group has participated in. So we do a lot of clinical trials for our patients. And the red circles are all the studies that have been terminated either because they had side effects or they showed non-efficacy or there were some safety signals. And then the 2 drugs that were approved were really resmetirom and semaglutide. And there's others that are showing a great deal of promise. So it's a very exciting therapeutic pipeline. Now, there's several molecules that have been identified that I think most of our field is now heading towards these 4 molecules. There are many agents that are in the works. So resmetirom has approved some conditional approval. So that's the green box. It's a surrogate endpoint because we're looking at biopsies to show that this drug is effective. And then the second part of the study, which is a longer-term study looking at what can you actually save lives? Can you actually prevent liver transplant? That study is ongoing, and we'll have data on that in the next few years. Similarly, for semaglutide, the part 1 of the study did meet those surrogate measures of biopsy-based decision-making, but now we have to see whether it actually saves life in the long term. I think our early experience is that both of these drugs will prove to be effective in the long term also. And we've learned so much from PBC, where the drugs were approved based on biochemical markers, but it took us another 10 years to show that those biochemical markers correlated with lives saved. So I'm pretty confident that unless there's some unexpected safety signal, that both of these drugs will meet that important threshold in a few years. The other drug which is important is lanifibranor, and there's others in this class, but lanifibranor is a phase 3 study that's ongoing right now. It has a side effect of increasing body weight, so that could be a challenge for some patients. But 20% of the world population has MASH without obesity, and I think this will be a good option for those patients. And then a very exciting new class is FGF21, which is a fascinating molecule. It's a hormone made by the liver, which goes to the brain and induces the brain to consume less alcohol and less sugar. So imagine that, it's everybody's dream come true. So we'll see how that goes, and we have several of these patients enrolled in this phase 3 study. So we'll see how it goes. Now, these drugs do have some GI side effects, so we'll have to wait and see how the story plays out. Now, a couple of other exciting areas of growth is the rise, I call it the era of metabolic medicine. And I think the driver of that, we're learning so much about human physiology and psychology, is coming from this class of drugs called the incretin receptor agonists. Most of us just call them GLP-1 receptor agonists because that's one molecule within that whole class, which is the most well-known. But there's others. There's one called GIP, or glucose-dependent insulinotropic polypeptide. In GI, we call it the gastric inhibitory peptide. The acronym is still GIP. And then a very exciting new class, which is glucagon receptor agonists, or GRAs. And now there are single, dual, and triple agonists in development that I think are going to be very, very important game changers. And these are drugs that affect the entire body's physiology. So this is a really important class. So besides semaglutide, which is marketed as Ozempic or Wegovy, the other dual incretin agonist is called tirzepatide, which is marketed as Mounjaro or Zepbound based upon its indication. And that's also proven to be very effective for MASH. So this is now a phase 3 study. There's no doubt from our clinical experience. I have almost 20% of my patients now are on tirzepatide because we have such a high overlap with type 2 diabetes population, and they are responding beautifully with fewer GI side effects. So I think that this is going to be a very important weapon in our armamentarium against MASH. So really looking for completion of this phase 3 study, which is coming. There's a triple incretin agonist, which is hitting all of the three molecules, and this is called retraditide. And in this, as you can see in the lower graph, it might be a little small, those numbers, but individuals who had weight reduction of 10%, which we think is very clinically meaningful for fibrosis regression, was almost 100%. 90% of patients will lose 10% body weight, which is when you expect to start seeing changes in liver fibrosis. So these are very powerful, very, very exciting drugs that will really change the way we treat our patients. What's most exciting to me, though, is the rise of the era of anti-cirrhosis medicines. And one of them, which is shown here, is a drug called efruxifermin, which is that FGF21 molecule. And that in a phase 2b study, this is not published yet, so I don't have published data, but it's showing an improvement or regression of cirrhosis. And if this pans out in the phase 3 study, that is going to be a game changer, because now you can actually take patients. We have, in my practice, about 1,000 patients with MASH cirrhosis who are not yet reached the stage of decompensation requiring a liver transplant, and this could reverse their cirrhosis. So we will have to go back and rewrite the pathology and medicine textbooks that I learned from, because I was always taught that cirrhosis was an irreversible condition. So this is a very, very exciting development if it pans out in phase 3 studies, which I think remains to be seen. So I think we have a very exciting future in terms of therapy. I think the future is going to be combination therapies. Which combination becomes the gold standard, I think, remains to be seen. From a purely patient advocate perspective, cost is going to be a huge problem for us, especially in the United States. I think it's a problem that we pay for the drug development for the whole world. It affects my patients. It affects some of you who might be on these medicines. And I think we've got to solve that problem from a bigger societal perspective. But I think in terms of the actual science, there's never been a more exciting time for us. Now, before everyone gets too excited about all of this, I can assure you that we're not solving the problem in the near future. There are going to be some major challenges that we will need to address. So I mentioned in the first part about the global consensus guidelines and the US guidelines now, the Endocrine Society, the Liver Society, the American Gastroenterological Association. Everyone is asking for FIB4 to be the first line for screening our patients at the population level. So the formula that we use is on the right. It involves age, 2 of the liver enzymes, and then platelet count. And the platelet count is important because if scarring increases, generally there is a hormone that the liver makes which goes down. And so the platelet count goes down. And then the second is because the spleen enlarges as pressure builds up behind the liver, and that traps platelets. So a combination of these two factors and probably other factors that we haven't quite figured out, there's a drop in platelet count. So it's a simple formula. It's embedded within our electronic health record system. It's very easy to calculate. Everyone understands these numbers. But it's a problem because there's some conditions when someone is below 40 or over 65, it kind of breaks down. Some people who have other reasons for having low platelets, it breaks down. Dialysis and kidney disease patients, it doesn't work as well. And if there's a lot of inflammation, it doesn't work as well. So I don't think we've solved the problem. It might be okay for a majority of patients, but we've got some work to do in this space. We asked the question in the UPMC database. We looked at 45,000 patients, and then we combined it with a very large regional network of 11 million patients. We asked the question, can we use FIB4 to find our patients with MASH very quickly? And we had some very sophisticated computer-based algorithms to rule out every other disease, including alcohol in some cases. But what we found was the majority of patients simply don't have the data in the electronic system, probably because PCPs don't check it. And we found platelet count is rarely checked in patients. ALT and AST, yes, but not platelet count. There's no reason to. And so that's a problem. We find many patients fall in this gray zone. We have to do a lot of additional testing for them. And then we also found there were lots of patients who had cirrhosis who had normal or near normal FIB4s, just because age is in that equation. So as our population gets younger, but more scarring is happening, this test may not be sufficient for them. So I think we've got some ways to go for diagnostic testing. I think the second test that we use, which is a FibroScan, also has some challenges. In my practice, the biggest challenge is patients that have a higher BMI. This test tends to overestimate that risk. And so they end up with too many unnecessary biopsies or too many MRI scans to further stratify that risk. I think we've got a long ways to go to develop blood-based biomarkers for MASH development. And then there are other challenges, just like with FIB4. The other important thing to keep in mind is that we talk about the liver, and we're very focused on the liver. I think this whole group here is very focused on the liver, but we have to remember that the liver is a very critical component of the body's metabolic health. In fact, it precedes development of heart disease by decades. It precedes development of diabetes type 2 by about a decade. And I think that we forget sometimes that we have to think about the liver as the canary in the metabolic coal mine. So our guidelines are saying if you have massled or fatty liver without inflammation or fibrosis, just go back to see your PCP. But if you don't do something about that at that point, this figure just tells you you're at risk for all of these other problems: pancreas, diabetes, heart disease, kidney disease, other problems that have been very closely associated with MASLD, such as sleep apnea, dementia. I think all of these are important factors. And some populations like type 2 diabetes, there's a 70% overlap with MASLD, and then there's about a 90% overlap with severe obesity. So we really have to think about population health from the perspective of overall metabolic health. And of course, the frightening thing from my perspective is the global prevalence of obesity. And what's most frightening is that the population group that is increasing, the obesity is increasing in, is the young population below 25. So the youngest birth cohort in the world is the one that's suffering from severe obesity as the highest prevalence. So that we've got to really stop and ask the question, what is going on here? And are we just going to be able to medicate our way out of it? Or do we truly have to think about this in a different way? And I think the answer will really lie in some fundamental changes to how we think about our nutrition, our food supply, how we eat, how we interact with food in general. And I think that this is a very interesting paper, a very well-done randomized clinical trial showing that alternate day calorie restriction and exercise resulted in a significant decrease in liver fat, and this was with very modest weight loss. So just to kind of break apart that relationship between weight. The other question we have to ask is whether food is addictive. I think we really have to ask that question in the modern world about what's going on with our food supply. And I think that this study, which was a clinical trial, an unbelievably well-done randomized clinical trial from the NIH by Kevin Hall, who's one of the most distinguished scientists in this space, showed that individuals actually who were given ultra-processed food ate more and they gained weight over a 2-week period of time. And this was all completely subconsciously happening in these patients. So this is a very thought-provoking and interesting paper. And then there have been some studies showing that ultra-processed foods have been associated with diabetes, obesity, cardiovascular disease. The evidence is low for MASLD, but I can tell you from my clinic, really, we know that the association is actually extraordinarily strong. We just haven't published the papers on it as yet, but there's no question about it. And then there was a recent paper from just a few weeks ago showing that a Mediterranean-style diet was associated with decreased risk of death in patients that had MASLD using the very large United Kingdom biobank, the UK biobank. This is, I think, a very important study that I want to highlight in the last few seconds, is that you can completely ignore weight loss, de-link weight loss from fat in the liver, and focus on reduction of added sugar and fructose. And this was a landmark study from UCSF. It was looking at children. They had about 40 children in this study, and they were put on a remarkably well-done study where they were given an isocaloric diet. So they removed the equation of decreasing calories, focused only on sugar reduction, and they found that there was a very substantial decrease in liver fat and fat production or de novo lipogenesis in the liver. So this is a very important and landmark paper in my opinion. I told you this already, that even when patients are responding to therapies, not everyone's going to respond. And this is the key part with all the GLP-1s and incretin agonists, is that when you stop treatment, the weight loss comes back. The weight regain happens almost immediately afterwards, so that people who come off therapy regain the weight by 1 year. So we have to really ask our patients if they're okay with taking these medicines lifelong. So if you started, you basically have to take it lifelong. And I'm not sure we understand the long-term safety of these medicines. So, as promised, right on time, Susanna, I'm not sure where you are. I have not heard the alarm go off. So I will end with the takeaways that, we're very excited about all of the dramatic advances that we've had. We have some very exciting therapies in development. I think it's going to be amazing for our patients. Yet we have some challenges in diagnosis, in awareness, in risk stratification, and certainly in therapy of these patients. And just to highlight my final point is that, yeah, we've got some cool stuff coming in terms of therapy, but really we have to ask the fundamental question about what's happening in our life outside of the clinic that's causing this whole pandemic in the first place. So I just want to thank a bunch of people that I work with. We have an amazing and large team, and couldn't do anything that we're doing without their support, and of course, very importantly, our funding agencies from the NIH. So thank you very much for your attention.
Isn't he wonderful? That was awesome, Dr. Behari. Learned so much. Give us hope. It is my pleasure to introduce the next session, which is a panel discussion on MASH. We have Dr. Maya Balakrishnan, who is going to moderate the panel. Each panelist has 15 minutes, and I will use my tone, so be mindful. Dr. Balakrishnan is a respected hepatologist and researcher at Baylor in Houston, and her work focuses on metabolic liver diseases, including MASLD and MASH. She is recognized nationally for her leadership in clinical care, population health strategies, and advancing equity in liver diseases. And Maya was also one of our co-chairs of our MASH coalition. She's a great leader in this space, and so it is my pleasure, and I ask you to help me in welcoming Dr. Balakrishnan.
Good morning. I'm delighted to moderate this panel. I want to go ahead and invite our panelists up to the stage. We have 4 speakers. So this is an exciting panel. Dr. Behari set us up really well for the morning. Until about noon, we're going to be focusing on MASLD. And this panel brings an interdisciplinary view of MASLD. We get to hear a perspective of MASLD from a patient, so we get to hear about the lived experience of MASLD. We're going to hear about MASLD from a clinician who takes care of this problem day after day. We're going to hear a view from the biopharmaceutical point of view with regard to drug development. And we're also going to hear a view from basic science. With that, I'll go ahead and introduce our first speaker. Our first speaker is Dr. Karen Jerome-Zapatka, a friend and someone I've worked with in this organization as well. She's a board-certified gastroenterologist who practices here in the Pittsburgh area. She's board-certified in obesity medicine, and she's also certified as a metabolic health practitioner. So what she's going to talk about is the evolution in our thinking and understanding of MASLD as a primarily GI liver disease to our thinking and understanding of it as more of a systemic and metabolic disease. So please help me welcome Dr. Jerome-Zapatka to